We are live.
Good evening, everyone. Welcome to iFocus Online, lecture number 558, Optics and Refraction, module number 33. Today we have Dr. Garvita Dabas from Center for Sight, New Delhi, who will be talking on optics of instruments, retinoscope and focimeter. The moderator for today's session is Dr. Supriya Samak Siri Ganesh. Ma'am has done her MBBS from Kempegowda Institute of Medical Science, Karnataka, and her MS from Father Muller Medical College, Karnataka. She did her fellowship in cataract and refractive surgery at Netradham Eye Hospital. Currently, she is a consultant in phaco and refractive surgery at Netradham Super Speciality Eye Hospital, Bangalore. Ma'am is one of the youngest surgeons to perform live surgery at the age of 28 years. She is actively involved in training and education and by organizing resident training programs like NERDS Eye View Netradham, Netradhama Zayas refractive surgery course twice yearly, and refractive training programs for international doctors. She is organizing secretary for the phaco festival in Bangalore. She has numerous presentations at national and international conferences. Welcome, ma'am. Over to you.
Good evening, everyone. Thank you so much for having me on this platform again. I would like to thank Santosh Honavar, sir, Dr. Ritika, Dr. Tulika, and the entire team of Center for Sight for doing such a great job with iFocus. It's my pleasure to invite and introduce um, Dr. Bhupesh Bhaktkoti. Sir has done his MBBS from Armed Forces Medical College in 2022 with a distinction in ENT and ophthalmology. Sir will be the chairperson of the session today. He completed his MS in ophthalmology from MUHS Nashik in 2010. He completed his DNB ophthalmology in December 2010 and was awarded a gold medal. He completed his fellowship in cornea and refractive surgery from PGI Chandigarh in 2016. Um, he's presently based in Pune and he's in the defense services. He has over 18 years of experience as an ophthalmologist. He's worked in prestigious institutes like AFMC, Command Hospital Pune, Lucknow, and Chandigarh. He's a recognized teacher with MUHS Nashik, having conducted over 1,000 corneal transplant, including lamellar grafts. His special areas of interest include cataract and keratorefractive surgery. He's a reviewer of reputed medical journals and has published in national and international journals. Welcome, sir. And it's my pleasure to introduce Dr. Garvita Dabas, who's going to be the speaker for today's session. She completed her MBBS in DY Patil, Mumbai, and MS, and she's a gold medalist. Um, she completed her fellowship in cataract and refractive surgery in Center for Sight and a gold medalist in FICO as well. Currently a consultant at Center for Sight, New Delhi. She's received various prizes in photography, paper, and poster presentations in many conferences, authored multiple journal articles, and delivered various international instruction courses as well. She's a co-author of multiple chapters published in national and international books. So over to you, Garvita, to take us live with the class.
Thank you so much for that kind introduction, ma'am. Thank you to iFocus as well for the opportunity to present the class today. The topic for today is optics of instrument, retinoscopy, and focimeter. I am just sharing my slide. I hope my slides are visible and my voice is clearly audible.
Yes, go ahead, Garvita.
Thank you. Thank you, ma'am. So for the class today, the first topic is retinoscopy and the optics of retinoscope. Considering the history, it was introduced by Bowman firstly in 1859. It has other names as well, like pupilloscopy, shadowscopy, skioscopy, umbrascopy, scotoscopy, and choroscopy. It is basically an objective method of finding out the error of refraction by utilizing the technique of neutralization. It is primarily based on the Foucault principle, which states that when the light is reflected from a mirror into the eye, the direction in which the light will travel depends upon the refractive status of the eye. Further, in 1873, F. Cugent, who's considered the father of retinoscopy, described the first retinoscope. By 1901, Wolf invented the first internally illuminated electric retinoscope, and finally in 1927, Copeland streak retinoscopy was designed. Types of retinoscope, basically there are either reflecting mirror retinoscope, which includes plane mirror, Priestley-Spitz mirror, which is plane and or concave mirror, and self-illuminated retinoscope like a spot retinoscope and a streak retinoscope. Reflecting mirror retinoscopes, they are a perforated mirror by which a beam is reflected into the patient's eye and through a central hole that we can see diagrammatically in the picture as well. So this is the hole through which the central hole through which the emergent rays enter the observer's eye, and the movement of the illuminated retina area is produced by either tilting the mirror, which can be either plane or concave. The advantages of plane mirror reflecting microscope are, number one, it's cheaper than the self-illuminated one. The disadvantages are that it requires a separate light source. There can be glare from the source, which can be annoying to the patient and hence difficult patient cooperation. It can also be a disadvantage that to check the axis and the amount of cylinder is difficult. Also, the intensity and beam of light cannot be changed or controlled. Therefore, as time progressed, we came towards the self-illuminated retinoscope, which consists of a light source and a mirror which are incorporated into one. Streak retinoscope consists of a light source, which is an uncoiled filament of light. A spot retinoscope creates a spot such as this, and a streak retinoscope produces a cylindrical streak of light such as this. So streak retinoscope basically has two parts, which is the projection system and the observation system. The projection system has a main purpose to illuminate the retina. This is the projection system where there is a bulb followed by a condensing lens which reflects light upon a mirror, which further sends the light towards the patient's eye. It consists of a light source, condensing bulb, the mirror, the focusing sleeve, and the current source of light. So looking deeply to it, the head, the neck, and the battery pack, if we consider these two images, so when you pull the sleeve down, the bulb may move down and the condensing light lens is fixed here. So the light can, when the lens is moved up, it can produce a concave effect, which can be seen through the peephole as seen here. And the bulb, when moved up, can produce a divergent ray of light. So projection system can either be a Copeland streak retinoscope or an American optical or a Welch-Allen type. The difference between the two, let's discuss the Copeland first. The method of vergence control is that the lens is fixed. As we see in this diagram, the lens position is fixed, only the bulb is moving up and down. Whereas if we see the Welch-Allen or the American optical system, when you move the sleeve up and down, it's the lens that is moving, but the source of light, which is the bulb, that is fixed in position. So a plane mirror effect is seen when the apparent light source is behind the retinoscope, creating a parallel light ray, and the concave mirror effect is present when the apparent source of light is in front of the retinoscope, creating a concave ray of light. Coming to the observation system, the main purpose is to allow the observer to see the retinal reflex of the patient. So this is the observer who is observing via the peephole. So the streak of light comes via the retinoscope through the mirror, goes towards the patient, and the light is reflected back from the patient's retina to the observer's retina. This constitutes the observation system. The advantages of streak retinoscope are that it is self-illuminated, therefore light source and mirror are incorporated in one and no separate source of light is required. It is also easily manipulated and the beam of light can be controlled easily in intensity and type. The advantages of streak retinoscope over a spot retinoscope are that the exact size of axis of cylindrical power can be found more easily by a streak retinoscope. Also, in high refractive errors, by using concave mirror effect, we can find the amount of refractive error. And by using enhancement technique, we can estimate the gross amount of hyperopia up to 5 diopters or more. So the optics of retinoscopy, there are mainly three stages: the illumination stage, the reflex stage, and the projection stage. The illumination stage is when the illumination happens of the subject retina, that is, light falls on the retina of the subject. The reflex stage is created when the reflex imagery of this illuminated retina is formed by the patient's dioptric apparatus, that is, when we can see a red reflex. Lastly, the projection stage is when this image is projected back by the observer. So as we can see, a source of light hits the plane mirror and then it reflects on the subject's eye, and with the movement of the mirror, the light can move. This is the illumination stage. The reflex stage, when the ray of light which falls on the subject's eye on the retina uh, is formed at a far point. So this is the far point, which is if it falls between the retinoscope and the eye, it can move against the movement or either with the movement. I will just discuss this in detail in the upcoming slide also. A projection stage is when this image of the far point is located by moving the illumination across the fundus and then noting the behavior of the reflex by the observer. So the prerequisites of a retinoscopy are a dark room, a trial set, a trial frame, a refractor or a phoropter, a distance vision chart, near vision chart, and a retinoscope. What is the working distance? So, working distance from the retinoscope is the distance between the retinoscope and the patient's eye. Typically, the dioptric power is 1 divided by f. So, the length of the average person is 66 centimeters, and the average distance that we take is also an arm's length. Therefore, at this particular distance, the power of the lens that is focused in parallel rays is at 1.5 diopters. If we consider other distances, 40 centimeters can amount to plus 2.5 diopters, and 100 centimeter is almost plus 1 diopter. This is the dioptric equivalent of this particular working distance. A fixation target is chosen. The target is generally given to be a large alphabet, which can be the 660 alphabet in the Snellen's chart. This is given so that the patient's accommodation may relax during retinoscopy. The patient is asked to explained about the test. The patient is instructed to fix on the distance target. The right eye of the patient should be examined by the examiner's right eye, and the left eye with the left eye of the examiner. And similarly, for the right eye, retinoscope should be held in the right hand, and for the left eye, the retinoscope should be held in the left hand. Working distance should be maintained ideally at an arm's length of 66 centimeter, and examiner should keep both the eyes open. So to observe the reflex, we have to see there is the movement of the reflex. If there is any oblique astigmatism present, the reflex will not appear vertical, rather it will appear a little tilted. When we move this vertical streak of light horizontally along the pupil, we observe how the reflex moves. And similarly, when we turn the streak of light in a horizontal manner and we move it up and down, we can see the reflex of the movement. The movement of the reflex, sorry. So if the streak and the reflex move in the same direction with no lens in the refractive apparatus, the refraction is either hypermetropia, emetropia, or myopia less than 1 diopter. However, if the reflex moves in opposite direction, the error is greater than 1 diopter. To explain this more further, when we are moving the, just a minute, when we are moving, yes, this is my pointer. When we do move the retinoscope and it moves with the movement, so we can either see myopia of less than 1 diopter, hypermetropia, and emetropia. But when the focus, in this case, the focal point is far away. But in this case, when the focus point is located between the patient and the examiner, the movement will be against movement, which is myopia more than -1. And again, when the focal point is located in the examiner. So that is the neutralization reflex that we see. A mnemonic by the name SPAM can be remembered, which is if there is same movement, it requires a plus power for neutralization. whereas against movement requires a minus power. What this means is that with hyperopic patients in motion, we need to add plus lenses to move the focal point towards the fovea, whereas in myopic patient, when the movement is against the motion, we have to add minus lenses to move the focus point back onto the fovea. So what is the direction of reflex? When there is no movement of red, reflex is indicated myopia of around 1 diopters. When it moves along with the movement of retinoscope, it indicates emetropia, hypermetropia, myopia less than 1 diopter. And movement of red reflex against the movement of retinoscope indicates myopia of more than 1 diopter. What are the properties of fundal request? We judge the fundal request based on brightness, direction of motion, speed of motion, and width. The brightness and speed of reflex is that the bright and fast shadow generally correlate with low degrees of refractive errors, whereas the dull reflex, slow moving reflex are associated with high degrees of ametropia. Width of the retinoscope also shows that the narrow width is seen in high degrees, whereas wide width is seen in low degrees of ametropia. So how do we identify the neutralization of red reflex? A neutral point is achieved when the examiner sweeps across the pupil and the reflex fills the entire pupil with no perceived movement. There are three main things: the streak motion, reflex width, and the streak speed. So streak motion, when we see the movement of the retinoscopy reflex, we remember the mnemonic SPAM, which is add for minus lenses and the plus lenses to neutralize it. Then for the reflex width, the beam will become wider as neutrality is approached for all types of refractive error. Streak speed, so as we reach the neutrality, the speed and brightness of the beam can be seen. When nearing neutrality, the reflex will be more brighter and it will move faster. The examiner has passed the neutral point with the corrective lens if the reflex begins moving in the opposite direction. So this is how we can check if we have reached neutrality or not. Finally, finding the cylindrical axis. In the presence of astigmatism, one axis can be neutralized with a spherical lens, and the second axis can show the movement of the reflex in the direction of astigmatism. So we can find the cylindrical power with three main methods. First is with two spheres, and then a sphere and a cylinder, and thirdly with two cylinders. So if we have two spheres, we can use one of them to neutralize the first power, and then keep on changing the sphere till the second axis is also neutralized. Finally, astigmatism is measured by the difference between the two spheres. Next is with a sphere and a cylinder. First, neutralize one axis with an appropriate spherical lens. Then neutralize the other axis with a cylindrical lens at the appropriate orientation. Finally, a spherical and cylinder retinoscopy may be read directly from the trial lens apparatus. So as we discussed, the neutralization point is the end point of retinoscopy in any meridian with the movement of the mirror. But when the real endpoint of retinoscopy is the reversal, where overcorrection by 0.25 diopter can also cause reversal of the movement, a slight forward movement should be caused with the movement and slight backward movement should be against the movement. Finding the cylinder axis break. A break in the alignment between the reflex in the pupil, which is the central reflex, and the band outside it, this is the band outside it, when the streak is not parallel, is one of the meridian. This can be determined by rotating the streak till the break appears. So we rotate the streak to align it with this outer streak. The width appears narrowest and intensity is the brighter when the streak aligns with the true axis. So as we can see, this is a normal vertical beam and this is the fundus request. This B image shows with the movement. The C image shows against the movement. Finally, we come to a neutral point, which is the point of reversal. In case of astigmatism, we realize the fundal glow is in a particular direction which does not align with our streak, and when we rotate our streak we can finally find the axis of astigmatism. There is another concept of straddling which is used to confirm the axis. This is performed with approximately correct cylinder in place and the streak is turned 45 degrees off in both the axes. If axis is not correct, the width will be unequal in two positions. Coming to the types of retinoscopy, there are two types, static and retinoscopic. Static implies that the patient is looking at distant object with accommodation relaxed. Dynamic retinoscopy is when the patient is looking at a near object with accommodation active. Dynamic retinoscopy techniques, there are multiple techniques. The most commonly used one is the monocular estimate method, wherein the positioning of accommodation relative to convergence is seen, and its target location is 16 inches, which is 40 centimeters, and the expected is the value is 0.5. Other methods are not dynamic, OEP, Bell retinoscopy, stress point, and book. So, wet retinoscopy is done with cycloplegic, and dry retinoscopy is done without any cycloplegics. The indications of wet retinoscopy are accommodative fluctuation, which are indicated by fluctuating pupil size or reflex during retinoscopy. Patients with esotropy or convergence excess, then a retinoscopy results significantly more positive or negative than the subjective result. The medicines that we use for cycloplegic drugs that are used are atropine 1%, cyclopentolate 1%, and hometropine 2%. And the deduction that we do for cycloplegics is 1 diopter for atropine, 0.5 diopter for hometropine, and 0.75 diopter for cyclopentolate. This is a tabular data that explains in detail. So atropine sulfate is 1% used less than 5 years old, 3 times a day, 3 days. A peak effect is 2 to 3 days, and time of performing retinoscopy ideally is the 4th day with duration of action 10 to 20 days. Post cycloplegic test can happen only 3 weeks of retinoscopy, and the tonus allowance it gives us is 1 diopter. Hometropine 2% is 5 to 8 years, 1 drop every 10 minutes, 6 times. Peak effect is 60 to 90 minutes, and after 90 minutes of installation of the first drop, we can perform the retinoscopy. Duration of action is 48 to 72 hours, and post cycloplegic test can be done 3 days after retinoscopy. The tonus allowance is 0.5 diopters. The cyclopentolate 1% drops can be used in 8 to 20 years of age, 1 drop every 15 minutes 3 times. Peak effect is 80 to 90 minutes, and after 90 minutes of installation, we can do the retinoscopy. Duration of action is 6 to 18 hours, and post cycloplegic test can be done after 3 days of retinoscopy with a tonus allowance of 0.75. Tropicamide 0.5% or 1%, not really used as cycloplegic for retinoscopy, can only be used for mydriatic, therefore no tonus allowance present. And finally, phenylephrine 5% and 10% used only as a mydriatic alone or in combination with tropicamide. Disadvantage of cycloplegic retinoscopy: temporary symptoms like blurred vision and photophobia, degradation of vision caused by abolition of the accommodation response, increase in ocular aberration as a result of dilated pupil, and adverse effects and allergic reactions to cyclopentolate are also heard of but very rare. Other problems in retinoscopy can be the red reflex may not be very clearly visible due to a small size, hazy media, or high degrees of refractive error. Leukocoria can also be diagnosed with it, especially in children. Thirdly, in keratoconus, we can appreciate a scissoring reflex. When there are patients with strabismus, it is easier to change the fixation of good eye so that retinoscopy can be performed along with the visual axis. Bruckner's reflex can also be seen in such patients. Retinoscopy in nuclear cataract can show index myopia and early changes, and spherical aberrations may lead to variation of refraction in the center and periphery of the pupil, which can be more marked in lenticular sclerosis. So, non-refractive uses of retinoscopy include opacities in the lens and iris can be seen against a red background. Extensive transillumination defects in patients of uveitis or pigment dispersion syndrome can be seen. Again, scissoring reflex can be seen in keratoconus, leukocoria can be diagnosed. Retinal detachment of involving the central area can also distort the reflex. So, reasons for a false reading may be inexperience, not alignment of the visual axis of the patient, a working distance is if not maintained, lack of subject's accommodation, defect in trial lenses, and lack of patient cooperation. Another part is the recording of the results for retinoscopy. So for dry retinoscopy, the net retinoscopic power is the gross retinoscopic power, which is given in a cross format that we find after a retinoscopy test, minus the working distance power, which is the working distance dioptric power that we subtract from the gross power. For the wet retinoscopy, to find the net retinoscopic power, we have to subtract both the working distance as well as ciliary tonus power from the gross retinoscopic power. As an example, this is an example of a dry retinoscope where the gross power is +2 ds / -1.5 into 90 with a working distance of 100 centimeters, which is 1 diopter. So to find the net power, we have a gross power minus the working distance power. This is the cross chart with a 90-degree and 180-degree. The gross power is +2, which means it works on both 90-degree axis as well as 180-degree axis. Further, -1.5 is 90-degree, which functions 90-degree apart. So it is -1.5 here. So the total power we get here is 0.5 plus. Finally, from both the numbers, we subtract the working distance, which is -1. So we subtract -1 from both and we get +1 spherical, which is working on the whole thing. And this is 0.5 minus, which is the cylindrical power. So our gross power will come out to be +1 with -1.5 at 90-degree. Next example is the wet retinoscopy. The given gross power is +4 ds with +1 at 90. Working distance again 100 centimeters, which is 1 diopter. And the patient has been dilated using atropine, which also has a ciliary tonus of 1 diopter. So +4 is acts on both 90-degree and 180-degree. Followed by a cylindrical of +1 at 90, which is apart 90 degrees apart. So at 180, total is +5. From both, we need to subtract working distance 1 and ciliary tonus of atropine 1. So total 1 + 1 is 2. So we subtract 2 from both. Now we have +2 and +3 here. So +2 is spherical, and since a cylinder works at 90, so we will have +1 at 90-degree. Coming to the next topic of our class, which is the Focimeter. So what is Focimeter? It is a lensometer or lens meter, which is a standard ophthalmic device, sometimes referred to also as the vertometer. The techniques and procedures for operating a lensometer is called lensometry or focimetry. The most common use of lensometer is to verify the accurate configuration and prescription in a pair of eye lenses by optometrists and opticians. If we speak about the history, the first design was done in 1848 by Antoine Claudet, who was a famous photographer, and he had designed a photographometer, which measured the photogenic rays. In the following year, he designed Focimeter, which was used to identify the correct focus of photographic portraiture. In 1912, Tropman introduced the first Focimeter, and by 1922, first patented projection lensometer was designed. The uses of lensometer are that the lensometer helps orient appropriately and mark uncut lenses, verifying the power of single vision, bifocal, trifocal, and checking the right amount mounting of eye lenses in spectacle frame. The device is used by ophthalmologists or optometrists to evaluate certain parameters specified on patients' prescriptions, such as cylinder, axis, sphere, ad, and in some cases even prism. This instrument is often used to verify accuracy of progressive lenses. It is also used to determine and mark the center of a lens and several other physical measurements that are essential for proper functioning of the lens. At times, the lensometer is used for a prior examination of patient's spectacle power to match with previous prescription. The measured ranges can be from plus 20 diopters to minus 20 diopters. There are mainly two types of lensometer, the manual and the automated lensometer. The working principle revolves around a lens having a focal length is used to image a target, usually a cross set of lines, and the user then places a spectacle power under the lens rear focal point. The light rays emerge from the spectacle lens, then pass into the eyepiece having the internal reticle, which I will show in the upcoming slide. The target is axially shifted simultaneously by the user until it is in focus, and then a condition occurs when the light rays emerging from the test spectacle lens becomes collimated. So what I mean, this is the collimator, this is the axis wheel, and this is the target, which is the dotted line and circle that are our standard target. So this is the standard lens, and this is the power wheel, and this is the lens table. From the observer's eye, this is the graticule that is focused. This is the adjustable eyepiece, and this is the objective lens. So a manual lensometer gives the accurate power of a lens and are used in optical industries. A manual lensometer is portable and can be carried anywhere, but a person needs to have a better idea to measure the power of a lens, especially for toric lenses. It works on the manual lensometer works on the principle of Badal principle, which according to the principle is when we place an eye at a focal point of a positive lens. This is a 8 diopter Badal lens, and this is the adjustable stigma with a diopter scale, and this is a mirror which is a beam splitter. So this is the spectacle plane, and this is the anterior focal point of the eye. So as per this principle, when we place the eye at the focal point of a positive lens, we can depict this virtual object's image between the anterior focal point and the lens subtending the same visual angle. So this is how we can detect the power of the lens also. This is the general description of a manual lensometer, where this is number 1, the adjustable eyepiece, followed by a reticle. Third is the objective lens, followed by a Kleplerian telescope. The entire part is the telescope, followed by a lens holder where we keep the spectacles, followed by an unknown lens here, and a standard lens given here. This is the illumination target, and this is the light source. The entire thing is the collimator, and this is the angle adjustment meter. And this is the power drum, which ranges from plus 20 to minus 20 with the prism scale knob. So the eyepiece is used for obtaining reading accuracies mounted over a screw-type focusing mechanism. A rubber guard is also placed in the eye at eyepiece to avoid scratching. A prism compensating device knob is used to read prism amount that are greater than 5 prism diopters. A chrome sleeve helps in rotating the lensometer reticle to align with the prism place. A lens holder handle is present and in place alongside the aperture. A spectacle table lever helps in raising and lowering the level of spectacles. A spectacle table provides the spectacle frame when the lens power is being neutralized. Marking control device, which is the lens marker, are pins controlled by the handle and used to mark the lens at the optical center of the prism reference point. Power drum is the hand wheel with readings of +20 to -20 diopter, and the scale of the reading interval is 0.12 diopters. Prism axis scale helps in orientation of the prism axis, and prism compensating device helps to verify large amounts of prism. Prism diopter power scale is also present, which displays the prism amount. Finally, a locking lever helps in elevating and depressing the position of instrument. Cylindrical axis wheel, it helps in orienting and neutralizing cylindrical axis. A filter lever can incorporate or remove green filter. And a lamp axis cover is for changing and altering manual lensometer bulb. So how to operate the manual lensometer? First, focus the eyepiece of the lensometer for the examiner's eye. With the power wheel set on 0, turn eyepiece as far counterclockwise as possible. Then slowly turn it clockwise until the reticule first comes into sharp focus. Put your spectacles. After testing a pair of glasses, always check the right lens first. So to calibrate, adjust the device to perform smoothly in order to get accurate power of the lenses. Eyepiece should always be focused manually. Power drum should always be level 0 as shown in the picture. And all the knobs should be placed rightly and the device should be neat and clean to avoid errors. To adjust the eyepiece, it is important to focus eyepiece so that the observer's eye is relaxed. In adjusting the eyepiece, the blurred black protractor as shown here is focused into a brighter, sharper focused retractor. For this, first the eyepiece is rotated anti-clockwise so that the protractor views is blurred. Then slowly it is rotated clockwise and stopped where it is sharp and clear. So this is a focused protractor. Finally, the spectacles are placed on the device with its front surface facing towards the eyepiece. There are two knobs on the lensometer, the lens top, which holds the lens and the frame in place, and the frame leveling knob, which makes sure the frame is leveled and helps in accurate axis measurement. So this is the target that is visible inside the eye, which is green inside the lensometer, which is green in color and appears when it's switched on. It shows the position of the optical center of the lens, and there is a ring of round dots at the center of the target. This represents the power orientation of the lens as it rotates with the lens rotation. These dots become small lines oriented in one direction in case of a toric lens. So how do you determine the spherical power? Move the lens such that the target is exactly in the center and rotate the power drum until target is clear and sharp. Stop rotating the power drum when the target is sharp for the first time itself. Always count the upper mark on the power scale for accuracy of spherical power. To find the spherocylinder, number 1, find the spherical power, then identify the cylindrical power, then find the axis. For this, move the lens so that the target is at the center, just like in the second picture. This gives the optical center location of the spectacle. Finally, rotate the power drum so that the central lines which are oriented in one direction are sharp. Thirdly, rotate the axis wheel so that one meridian of the target is parallel to the orientation of the central line. Only one meridian will be sharp at a given target. As this is 180-degree sharp in this picture, the power can be the cylindrical power at 180-degree. Now rotate the drum so that the opposite meridian is sharp. This one. So it is since 90-degree sharp, we can write it as cylindrical power at 90-degree. So to finally write the power, as the lensometer reading gives a toric lens in two cylinder format, we need to transpose the power and write in spherocylindrical format. Other uses can be determination of a bifocal lens, where it measures the distance correction of a bifocal lens. The optical center of a conventional bifocal is just above the horizontal line of the bifocal lens and read the near correction from the center of the lower segment. For determining add power, turn the glasses around from the front vertex. Other uses can be determination of progressive glasses, where the center is located to make the reading accurate, and otherwise is similar to a simple lensometry. However, manual lensometers are for progressive glasses, automatic ones perform much better than the manual lensometers. Determination of prisms. As we know, prism deflects the lensometer target away from the center of the reticle, and the target is deflected in the direction of the prism base. When viewing the mires, the lines may be off center. The rings inside the lensometer are measured at one prism diopter. So the number of rings from the center will give us the amount of prisms in glasses. Other important points to remember: always focus eyepiece before using instrument. Concentrate on central circular orientation of dots, especially in toric lenses. One meridian of target should always be parallel to the orientation of central small lines in a toric lens. Each dot at the center will not be round, instead, they will be small lines oriented in one particular meridian. Except the protractor, everything may be blur when a lens is placed. The target moves with the movement of the lens, and instrument should not be used more on battery. Limitations of manual lensometer include that although it is good for single vision glasses, it can misguide in terms of bifocal, trifocal, or even progressive glasses. Power can vary with 0.25 difference, and not 0.12 diopters difference. It is difficult for progressive lenses and can cause even damage to contact lenses. Automated lensometer may offer fast, easy, and accurate measurements for single vision, bifocal, progressive, and prisms. Automatic measurements can be taken quickly by simply positioning the lens on lens table. Progressive lenses are recognized and measured automatically with the rate of addition and diopter change graphically displayed. So this is a graphical representation of the screen with a printout of a spectacle. The principle is the degree to which a beam of light is deflected as it passes through the lens depends on the focal and the prismatic power of the lens and the distance from its optical center. The working is that a square pattern of 4 parallel beams of light is passed through the lens to be tested, which is quick, easy, and requires minimum expertise. The accuracy is variable with machine to machine. Other features of automated lensometer are UV transmittance measurements, pupillary distance measurements, measurement of soft and hard contact lenses, space saving vertical orientation, full color tilt screen for easy viewing, easy accessible menu to customize settings, data output options like built-in printer and even USB ports, and also it can be configured to your interface with EMR systems. Advantages over manual lensometer include it can be used for accuracy in all conditions like proper centration, decentration, axis marking. It can measure power of near addition lenses like bifocal progressive, which are made easier. Some models can also measure the AB number. The lens can also be measured with 0.01 diopter, 0.12 diopter difference. IPD measurements of lens mounted spectacles, and also it is less time consuming in a clinical setup. So thank you. I hope I covered the lensometry and retinoscopy extensively.
That was a very comprehensive class on both retinoscopy and focimetry. I think you explained all the concepts really clearly. Pupesh sir, would you like to add anything?
Yeah, first I would like to thank Dr. Garvita for covering this very important topic, not only for the exam point of view, but I would say also as a clinical when you're doing a practice. So what happens is that retinoscopy nowadays most of the new generation PG students, they want to run away from it because of the availability of the auto refs. But then the importance of retinoscopy in supine patients, older patients who are bed bound, especially in children's. If you are doing cataract surgeries and other things, so then EUA in children, you definitely require to have a very reasonable refraction. You are following up a child in a ROP screen, I mean, in a ROP child. So all those things. So retinoscopy cannot be overemphasized. It is very important for practical purposes, for as well as for exam purposes. Again, a lot of old timers, they are very, very fond of refraction. And we have also seen the times of the spot retinoscope. But nowadays, I think the streak retinoscopy is what is quite affordable for most of the PG students. So just a very 2, 3 points, very well covered. But I would just like to emphasize the most of us, we have the streak retinoscope, which is the Welsh-Allen or the Heinz one. So there, put the sleeve down, because then if you put the sleeve up, then it will act like a concave, and the reflex will move in the opposite directions, and you will get confused. So to make it clear, just keep the sleeve down. In Copland is the one which we don't have. So there you are supposed to put the sleeve up to get that plane mirror effect.
Yes.
Secondly, about the wet retinoscopy, as has been rightly said, in children, I would like to bring to notice to everyone that uh, cycloplegic refraction is a must. It's a must. I think less than 7 years, if you're doing 7 to 10 years, you can't put the child directly on a refractometer, and whatever the reading comes, you prescribe this thing. At least for the first time when the child is being prescribed glasses, a wet refraction, ideally using a cyclopentolate at least, should be used. And then once you have documented it, then if suppose it comes as minus as myopia, then it is not a induced myopia. It is not a many times because of accommodation, they spasm, they do accommodate very especially low hyperopes, and it can cause a induced myopia. So that is I think a wet refraction is a must for prescribing a child prescription glasses for the first time. uh, Third, a very practical small tip. We talked about three things: focimeter, prescription, and refraction. That is a wet refraction. Now, all three of them, especially the refraction and the prescription writing, creates a huge confusion. It still creates confusion in my mind. So, just to uh, keep things very, very simple, and as a rough guidance, the retinoscopy and the prescription will always be 90-degree whenever you're writing the cylinder part, and the prescription will be same as what will come out in focimeter. So that is just as a this thing, because you do get confused. You get a +2 in horizontal, +1 in vertical, and you are, where should I put the 90-degree at? Where should I put the cylinder at? Is it at horizontal meridian, or is it as the vertical meridian? And one last thing about focimeter, the manual focimeter, which you talked about. Again, not many. I mean, it is very difficult to actually. For a sphere, it is very easy. Anybody can do it. You just have to this thing. But for cylinder, just thumb of rule is you have to. The thinner lines are the ones which you have to focus first. They tell you the sphere, and the thicker, broader ones are the one which is cylindrical. So you do first the sphere one. In case if cylinder is coming first in focus, then you rotate it 90-degree and try to bring the sphere one first. And then you add on to that. So you always calculate the sphere first. So focus on the thinner lines. So that is it. I mean, but nowadays, most of us want automated lensometer, and it's very easy, very convenient, and yeah,
Yeah, thank you
yeah,
so
that's all. I mean, yes.
Thank you for your inputs. That was so valuable. Yeah, just a couple of mistakes that usually residents or rookies would make is that one is the working distance. So, for example, me personally, I keep a shorter working distance because I'm shorter. So, I would keep it at 50 centimeters and it would be +2. So, don't keep a fixed standard working distance irrespective of your height or at what distance you're doing it. That's one thing to keep in mind. And yeah, if you forget to actually subtract the working distance, then you end up over minusing the hyperopes and over plussing the myopes. So that can lead to a significant refractive error. And yeah, sleeve up, sleeve down, absolutely, that's really important to keep it in the plane mirror mode. The whole thing is opposite if you keep it in sleeve up position. So sleeve down is standard. Sleeve up, I think in very small pupils, some people use it to, in a non-dilating pupil, it can be useful. And I think one important concept that I just wanted to kind of touch upon is a prescription for contact lenses. So there is a concept called back vertex distance that not everybody is very clear on. So I'll just take a minute to, um, you know, basically the distance between the back surface of any spectacle and the surface of the cornea is the back vertex distance, and normally we keep it at about 12 centimeters, anywhere between 10 to 14 centimeters. So why does this matter? This matters because as the lens keeps moving closer to the eye, the minus lens becomes less minus and the plus lens becomes more plus. And if it moves farther from the eye, the minus lens becomes more minus, plus lens becomes less plus. So the position of the spectacle on the patient's nose really matters. You may have done a perfect refraction, and the patient can come to you with a residual, with a refractive error, not a proper glass prescription, and they can come and, you know, really complain about that. So, I mean, in low power lenses, this really doesn't matter, but in higher powers, more than -4 or +4, this really matters the most. So, if you fit the lens closer to the eye, just keep for high minus lenses. If the lens is placed closer to the eye, it keeps becoming less minus. For example, if this prescription is -8 at 12 back vertex distance, but the frame is actually sitting at about, let's say, 8 millimeters, some about 4 millimeters closer, the effective power becomes minus 7.25 about. So the patient feels blurry at distance. So then you have to just adjust where the lens is sitting on the eye. So that's also really important.
Yes, very rightly brought out about the vertex distance. Yes. I have one question for Dr. Garvita.
Yes, sir.
Dr. Garvita, I want to ask you how much of emphasis is given, I mean, nowadays to suppose to PG who is appearing, who is undergoing a course. So how much of actual emphasis is being given nowadays for refraction? As far as you know, I mean, how much people want to learn about it. And I mean, Focimeter is probably little out of this thing. It is probably more for theory, but then refraction is something which we as ophthalmologists should definitely know. So how much
That's
of
right.
that?
Sir, in our institute, at least at Center for Sight, we have DNBs, primaries, and secondary. For the first 1 year, they have regular refraction postings where they practice retinoscopy and they practice refraction on the patients. So even we routinely send our patients to just cross-check the optometrist refraction as well as our DNB's refraction. So for the first year, definitely they're posted in the refraction clinics.
Yeah, so I think that's very important, and especially for DNB, definitely you'll get an OSCE's section,
Yes,
definitely for refraction, even for FICO and all. I mean, you are appearing, so optics is refraction is very important.
true, sir.
So thank you. Yes.
And yeah, even practically, I mean, if you're getting into refractive surgery also for certain types of procedures, especially things now like press beyond, the surgeon has to do the refraction and check the refraction at least themselves before entering into the machine and doing the treatment, because it is quite nuanced and has a lot of steps. So it's really important core foundation to have that concepts clear.
Yes.
Yes, I think I would share my personal experience. Now, I am a refractive surgeon, so I would say more than the machine, more than the patient selection, it's your refraction which will determine your result.
Absolutely.
Yes, definitely the surgery will make a difference, whether, how sooner you have after lifting the flap, all those smaller things will definitely matter. But then refraction is the single most important factor which will determine how good a result you are able to give post refractive. So as a rule, I definitely, to all my refractive patients, I do the refraction myself. I check it, cross check it 2-3 times. So that is, I'm very, very particular about refraction. So it has to be, I mean, so what happens in many bigger centers is that optometrists, very senior experienced optometrists, they do it. Like even probably at your places, Center for Sight, even in PGI, AIMS. But I am in a defensive setup, so I do it myself, and it cannot be overemphasized. Again, refraction is, I mean, is the key to your having a good refractive outcome. So
Very well said, sir. Thank you so much, Dr. Garvita, for the excellent class. And
Thank you.
yeah, I think we can wrap up if we don't have any other questions or comments. All right. Thank you so much once again for being here tonight. It was really valuable. And see you all in the next session.
thank you, thank you.
Thank you, ma'am. Thank you, sir.